Today we're going to be discussing a recent scientific advisory that we prepared for the American Heart Association regarding the endovascular treatment of patients with large core acute ischemic stroke. I want first to thank all the co-writers of this statement and the American Heart Association for commissioning this important paper. As many of those of you in the audience would know, the last few years have marked a change in the way we have been applying endovascular techniques for the treatment of patients with acute ischemic stroke. In the setting of acute ischemic stroke, core ischemia means the territory of the tissue of the brain that is irreversibly damaged. And since the beginning of the endovascular therapies with the 6 pivotal clinical trials, we have been restricting the number of patients that we treat to those that have relatively small cores of a stroke. The use of the Alberta Stroke Program Early CT or aspects has been broadly applied in the definition of those sizes of core in the different clinical trials. In the 6 original clinical trials, usually patients were enrolled if they have an aspect that was larger than 6, meaning that those with very large core strokes were excluded. In the diffuse and done studies, those criteria were expanded beyond 6 hours and included the use of CT perfusion. Usually predicted core was then considered for those patients that have a cerebral blood flow of less than 30 milliliters. Therefore, the majority of patients that we have been considering so far for treatment and the guidelines for the acute ischemic stroke treatment from 2019 define core in a time-qualified manner. There was patients with less than 6 hours of ischemic stroke, and generally they have aspects that were more than 6. For those patients that were between 6 hours and 24 hours, there was an expansion based on the selection criteria of the CT perfusion. The idea was that maybe patients that have very large core strokes would really not benefit from the endovascular interventions. In the last 2 years, 6 clinical trials have changed our perspective in the benefit that endovascular techniques have for these patients. The scientific advisory that we prepared was commissioned to review this data, to present it in a condensed way, and to provide some fundamental guidance for future guidance of the American Heart Association regarding the management of patients with acute ischemic stroke. The commission group reviewed all the data available, and we reviewed the aspects of how the trial had been designed, the eligibility criteria, the inclusion, exclusion, and the outcomes of the patients. The scientific advisory presents in a very concise manner, but very detailed, all the considerations that were taken in these important 6 clinical trials that attempted to expand the use of endovascular techniques for those patients that have large core ischemic stroke. When we analyzed the 6 clinical trials that were recently completed for the treatment of patients with large core ischemic stroke, we found that the majority of them included patients that have aspects 3 to 5. That means was larger than in the previous pivotal trials, however, still within a volume that some people would consider not extremely large. There was only 1 clinical trial that consistently and systematically include patients with very large acute ischemic stroke cores, that is aspects 0 to 2. In that clinical trial, there were some restrictions of time. Most of the patients were included within 6.5 hours from the last known well, and this was restricted also for patients which ages were younger than 80. All the clinical trials have very good design. From the methodological perspective, they were randomized with blinded endpoint assignments and have generally low levels of deviations, which gives a lot of confidence in the levels of evidence that they provided. Several aspects were analyzed in these clinical trials, including fundamentally as primary endpoint the ability of the patients to be functionally independent. Other outcomes that were evaluated included the independence to be able to walk, and other concerns that arise when you are considering treating patients with large core stroke, things like symptomatic hemorrhage, mortality, or rates of decompressive hemicraniectomies. Regarding the primary outcome of functional independence, all the clinical trials show benefit for those that were treated with endovascular therapy. That benefit, if we summarize it, reduced significantly the amount of patients that were dependent at 90 days from the initial treatment. That was significantly better than in those patients that receive only medical management. The secondary or the additional outcome that was also measured of independent ambulation was even more notoriously different in favor of those patients that receive endovascular treatment, with almost 36% of them being able to deambulate independently compared with 19% in the medical arm. Regarding the complications, symptomatic hemorrhages were seen in different degrees in the different clinical trials. In 4 of them, they were nominally lower. In 2 of them, they were nominally higher in the endovascular group compared with the medical management group. However, this didn't reach any statistical significance and clearly didn't affect the clinical outcomes of the patients at 90 days, which were favorable for the endovascular group. The compressive craniectomy was not seen to be more on one or another of the treatment groups, so it's difficult to tell that there was a benefit in that sense. In terms of mortality, most of the trials show benefit in reducing the mortality of these patients at 90 days. In summary, the results of these 6 clinical trials are very positive for the application of endovascular thrombectomy in patients with large core stroke. The improvement in functional independence was significant, with a functional independence of 19.5% in patients that went to endovascular treatment to a combined comparison of only 7.9% in those patients that receive medical management alone. However, it's important to notice that this functional independence is still limited. Only 20% roughly of the patients reached that level. There was a little bit of a bigger impact in the ability of these patients to walk. But still, patients with large core stroke have significant morbidity that needs to be considered. It is clear that these trials show the benefit of the endovascular therapy, with a calculated necessary number to treat or number needed to treat of 8 to prevent 1 patient from getting a functional dependency. However, it's also important to observe the differences in the clinical trials and some specific aspects of the populations that were included, because that can impose some limits in the generalizability of that data. For example, age was one of the main constraints. Most of the patients that were enrolled in these trials were generally younger patients, and there was a limited number of those that exceeded 85 years of age. In particular, in those cases, many of them were treated only early or with a specific imaging criteria to be sure that there was not flare abnormalities or that the core was not as big as a 0 to 2. A second factor that is important to consider is the level of pre-stroke disability. Consistently, all the clinical trials, including patients that have modified ranking scales of 0 to 1 in their inclusion criteria. There was one that was slightly more liberal to 2, but the large majority of patients were functionally independent before being included for treatment. So in conclusion, our paper shows a summary of the last 6 clinical trials that have evaluated the role of endovascular thrombectomy in patients with acute ischemic stroke. The results change the frame in which we have been applying this technique for patients with acute ischemia, and question the reversibility or effects of the traditional presumed core in those patients. This opens very interesting opportunities of research regarding other aspects that need to be considered. From the practical perspective, it is clear that endovascular thrombectomy offers benefit in terms of functional independence and independence ability to walk for patients with large core acute ischemic stroke. And we look forward to the development of guidelines that include these concepts, as well as future research that clarify in those patients that were not always included in these trials, the potential benefit of using endovascular thrombectomy for the treatment of their acute ischemic strokes. Once again, I want to thank the American Heart Association for commissioning this very important paper, and I encourage all of you to review it. It is very carefully done and contains a significant amount of details and data that is provided in the supplementary materials and in the main paper. Both of them would be a very useful resource for you to decide when to treat patients that present with this condition. Thank you.